Gina, tell me about your beautiful face. What is area that when you wake up in the morning bothers you?
One of the things that I would really love to have some improvements is like right here, and also this marionette lines here, and of course my neck is something that is turtleneck. I don't like it.
And Gina, have you lost weight within past few years?
20
big
kilos.
20 kilos. That's about like 35 pounds, I think. So first, I'm going to give support to the areas that need support, such as I'm going to go to mid cheeks straight with the Radiesse. I'm going to go to chin areas that need support, the gonial angle before the chin. Under the skin, I see a lot of laxity issues. So I'm going to pull the skin from the side before I go to the nasolabial fold to the mid face. So we're going to do kind of like a facelift from the side by using the Radiesse, hyperdilute, and a straight Radiesse. Lift her face, kind of give her a liquid facelift. I always start from the top and I come down. If patient is here for both tox and filler, I do all the fillers first and I do tox at the end because I want them to be upright. And the areas that so for example, if I'm going to the cheeks and I'm close to the eye, or if I do her on the eye with Belotero, I would leave her crow's feet for next time and when she comes for follow-up. Definitely 100% do the follow-up because follow-up helps you see the patient again. If there is other areas that you want to recommend, talk to the patient about it, and also see your work. Assess the patient, make sure they're happy. If you're a new injector, I want you to start with needle first before you move on to cannula. At least you need 6 months to a year of experience before you move to cannula. The only reason that is difficult is finding the right plane, and you don't want to be injecting into the muscle. With the Radiesse, you want to be on top of the bone. With hyperdilute Radiesse, you want to be on the subcutaneous plane. Any questions? Aspiration with Radiesse is only possible if the needle is fresh. So on these two areas, I'm going to aspirate and I'm going to stay lateral. So the infraorbital foramen is right straight from the mid-pupil down, but it's a little bit towards the inner nose. I'm going to be away from it, a few millimeters away from it to be safe. So I'm thinking it's going to be around here. So I'm going to stay away from it on this side. This is her zygomatic arch, and this is the infraorbital foramen. I'm going to stay lateral to that. I'm on top of the bone. I pull the tissue out, and I'm going to try to aspirate. I'm not pushing my needle against the bone. When my needle is touching the bone, I come out about maybe 1 or 2 millimeters, so I give some space for my filler to sit there. If my needle is pressing on the bone, the filler goes from side of the needle. It doesn't fill up exactly where I want it to be. Even for HA, when I'm injecting, when I feel the bone just slightly out, not a lot, you're still on preosteum level. Okay, just like slightly give the space so you can make sure that your filler is there and not pushing to the sides. We just did like 0.2 and it looks pretty good. Coming to the other side. And if your patient has a malar mount or SOOF, you don't want to be injecting in that. Go around it.